We will get started. Hello, everyone, and welcome to what is the first in our series of 10 webinars that the Oregon Office of Rural Health is hosting, focused on critical access hospital finance and operations. Today's webinar is Best Practice Checklist, a CAH financial and operational performance webinar. I'm Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health, and I'm joined here today by our presenter, Jonathan Pattenberg, as well as Stacy Rothwell, who is the Office of Rural Health's Program Manager and is focused on CAH quality improvement. Stacy's going to be here in the background monitoring your questions, and we'll get to how you're going to enter those and ask them in just a moment. All right, Jonathan, next slide, please. Before we get started, I just wanted to go over a couple of logistics. The audio has been muted and the video is turned off for all attendees. Select the ellipsis on the right of your screen to populate the chat feature. And please use that chat feature to ask your questions. As I mentioned, we're going to monitor those for questions and ask them of our presenter. We'll also have a Q&A session at the end of the webinar as well, where you'll be able to ask questions. If you'd prefer, you can also raise your hand by clicking the hand at the bottom of the screen. And then we can unmute you so you can ask your question live. The presentation slides and recording are going to be posted shortly after the session on our website at the link on the slide. I'll put that link in the chat in just a moment after I'm done with the introductions. So next slide, please. As I mentioned a moment ago, this is the first in a series of 10 webinars that we're hosting with a focus on CAH finance and operations. And you'll see the next 9 webinars listed on this slide. You can also find more information on the ORH website with the link that I'm adding to the chat in a moment. And you'll need to register for each of our sessions individually. You can register for as many as you'd like to. And with that, I'm pleased to introduce our speaker with us today and for the next 10 webinars is Jonathan Pattenberg, who's a principal at Wintergreen. Jonathan is an accomplished, results-driven senior executive with nearly 20 years of progressively responsible experience advising nonprofit, for-profit, and government entities. Over the past 6 years, Jonathan has worked with entities ranging from independent practices to multi-state healthcare systems on how to leverage rural opportunities to improve financial and operational performance. And prior to that, Jonathan served as Chief Financial Officer and Chief Operating Officer for a 21-bed nonprofit critical access hospital. So I'd like to welcome you, Jonathan. Thank you so much for being here and sharing your expertise, and the floor is yours.
Thank you very much, and very excited to present to the collective group today. Now, when we talk about the different topics, and Sarah really did a great job at emphasizing that this is a multi-part webinar series. Now, the purpose of today's presentation is to really lay the foundation and the framework for what we're going to be talking about over the coming. Now, because as a critical access hospital, there's many critical things that are relevant, whether it's reimbursement structure to service delivery, to access to care, staffing, all of these play a vital and critical role in the ability to provide services going forward. Now, as a critical access hospital, we operate in a unique environment where we receive distinct reimbursements for the services we provide, and we also receive cost-based reimbursement for those services for providing them to Medicare patients. Now, as we talk through the presentations coming forward, it's very much under the framework of ultimately rolling everything back to the value to the community. Now, when we talk about the value to the community, there's really different ways to approach that. One thing I always like to emphasize, particularly when we're talking about a rural environment, is there is no one-size-fits-all approach to healthcare, particularly in rural communities. As you start to operate in an environment, the staff you get are different, the providers you get are different, the competencies that those staff have are different, the patient need and demand for services, it all varies drastically across the healthcare landscape. Even in a state such as Oregon that has hospitals across the state, we have different services and different patient panel sizes and populations, and all of those different things ultimately dictate the services that we can provide and whether or not we can do it in a financially sustainable way going forward. Now, when we talk about the different things on this presentation today, it really all rolls back to that value to community. Now, when we start to drill down and determine how we're going to figure out the value to community, it really rolls up to strategy and operations. Now, what we've seen in today's environment is oftentimes there is a disconnect between the strategy and the operations. Strategy very much focuses on the future direction of the organization and what ultimately we want to achieve. Now, whether we're a nonprofit entity or whether we are in a system relationship, the strategy can vary drastically as we continue to operate as an organization. Now, what we really have to start doing is figuring out ways that we can merge operations and strategy together to start to improve financial and operational performance for our organization. Now, when we talk about the CAH best practices today, it's really around the framework of identifying different opportunities that we can look to leverage as a means to improve both our financial and operational performance. Now, as we walk through the presentation today, you're going to see several things on the screen. Really, it's framed around a checklist as to different things you can ask yourself, are we performing in these areas or are we not? Now, I'm not going to go through each different bullet type. I'm really going to hit on different high points and really frame the different presentations that you'll also see in the coming months by emphasizing different critical areas, whether it's revenue cycle, whether it's provider contracting, whether it's staffing, whether it's med surg. All of those different areas play a vital role in the ability to continue providing services going forward. Now, when we look up on the screen, we can see strategy is really off to itself on the left. Once we get into operations, it very much breaks down into financial and quality. Now, when we look at the healthcare landscape is probably one of the most segmented or siloed entities or industries in the country. And the reason for that is because oftentimes we see a disconnect between those that are providing the quality functions and those that are providing the financial functions. And it's the realization that we've gotten into this environment where the quality people or those providing the clinical functions do not have a comprehensive understanding of the financial services, and those that are providing all of the financial services do not have that comprehensive understanding of the quality and clinical services that are being provided. As we start to look at how we can break down those silos, and when we talk about the silos themselves, we have silos that include finance and quality, we have administration, we have staffing, we have providers, we have nurses. There is a ton of siloing across the organization. Those organizations that are truly starting to achieve outcomes and performance improvement are those organizations that have started to break down the siloing between finance and quality. Now, to do this, we really have to come to the realization that in today's times, finance has a direct impact on quality performance and patient outcomes and services has a direct impact on financial performance. We can no longer continue to operate in an environment where finance is doing financial things without taking into account quality, and quality is doing quality things without taking into account finance. We have to start to bridge the gap and merge those two areas together to start to realize true operational financial efficiencies across organizations. Now, when we roll everything back to that strategy as a whole, again, everything rolls back to the ability of value to the community. How we determine value varies depending upon who we're talking to. If we're talking to a CFO or somebody that's on a financial mindset, value to the community is obviously really rolled up into the reimbursements we're receiving. Is it done in a financially sustainable way? And all of those things to that degree. When we start looking at value to the community on the quality side, it's very much patient outcomes, access to care, all of those different things for determining the quality and determining the overall value. We have to realize and start breaking down those silos. Now, when we talk about the evolution of improvement models, and everything we're going to talk about today and in coming presentations is really looking at different opportunities as to how we can improve performance of organizations. As I talked about a moment ago with the siloing and the segmenting of different parts of the industry, if we go all the way back to the 80s, we had quality that was its own segment, really under quality assurance. We had revenue cycle that did those functions, whether it was point of service collections, whether it was claims adjudication, coding, documentation, substantiation, and all of those different factors. The last area was really around finance, and that was really much segmented into budgets and statements. Now, all the way through the 90s up until the early 2000s, it really wasn't much change. We moved from quality assurance to quality improvement. Revenue cycle, very in large part across the industry, remained as a separate subunit, and finance continued with budgets and statements. It wasn't until we got to about 2000 that we really started to see a merging of the different functions in those three different cohorts. We saw a merging of revenue cycle and finance. And it was really done because of the realization that revenue cycle had a direct impact on the financial performance of organizations. And we really started to roll that up under CFOs or other directors of finance to start looking at the implications of revenue cycle on the financial performance of the organization. Claims processing, first pass, all of those different metrics started to become of importance. Also, as we started to move forward towards pushing out EHRs and different things from a technological standpoint. But nonetheless, quality still remained very much separate, focused on performance improvement now. Those organizations in today's environment that are outperforming the broader industry are those that have looked at how to merge performance improvement, quality improvement, revenue cycle, financial sustainment, all into a single collective unit, really focused on how we can improve outcomes for an organization. Now, I'll give you an example. A few months ago, I was visiting a hospital, and we ended up meeting with the revenue cycle director, and then we also met with those that were responsible for the quality. And at this organization, they had two separate committees. They had a revenue cycle committee, and they had a quality performance improvement committee. And when we started looking at the metrics of the two committees, we realized that some of the metrics were actually competing with the metrics of the other committee, to the point that if revenue cycle were to achieve all of the metrics under theirs, that the quality side would not have been able to achieve all of the metrics on their side. And vice versa, due to the cost associated with some of the quality improvement metrics, if they were to achieve every metric on their side, the revenue cycle and the performance improvement to that degree would not have been able to achieve their metrics on their end. So again, we have to start breaking down the siloing, and we have to come to the realization that no longer can we operate in an environment where quality continues to do quality stuff and finance continues to do finance stuff. We have to come together under a single multidisciplinary team that is really focused on performance improvement across the broader industry. Now, before we get into the specific CAH best practices, I'm going to lay a little bit more of the framework as to how we want to start envisioning and looking at our organization. Now, we have to start breaking things out into functional areas, and I've broken them out into four main functional areas: operating, financial, value, and market. Now, it's under the realization that each one of these plays a critical role in the future financial solvency and the success of your organization. As we look at things such as new market entry and increased competition, that can impact financials, that can impact staffing, that can impact the market. As we look at the market itself and things such as payer contracts and value-based initiatives, that can impact financial performance. So it's, again, coming to the realization that each one of these play off one another and will ultimately drive the financial performance and the ability to provide additional services. Now, I'm sure all of you attending the webinar, particularly as we've come out of the COVID pandemic after the past couple of years, are in a position where you've continued to see volume decline, cost increases, service disruption, and all of those different factors. As we come out of the COVID pandemic, we really have to ensure we're positioning ourselves effectively to continue to meet that patient demand, but in a financially sustainable way going forward. We have to start to realize that as we select certain metrics and as we drive performance improvement, we have to start pulling things from different areas. In addition to that, one of the biggest opportunities I see for organizations as they're selecting financial metrics or performance improvement metrics is to realize they have to select both macro and micro metrics. Oftentimes, organizations will focus predominantly on many of those macro metrics. I'll give you an example: accounts receivable, so net days AR. They'll say, oh, we want to achieve a 45 days net AR. The problem is that there's about 1,000 different things that go into making up net days AR. You have clean claim ratios, first pass, documentation, lagging claims, did not final code, did not final bill. There are so many different things that make up net days AR that it's impossible to truly drive performance improvement by focusing on solely a macro metric. So what we have to start to do is position ourselves and start to select micro metrics to also start driving those initiatives. If we want to focus on net days AR, maybe we also want to focus on clean claims rate or first pass rate or different things to that degree, which again rolls up into the net days AR, but is also a specific function itself that allows us to get much more granular into the processes itself. Now, when we start to talk about best practices for critical access hospitals, one of the things that's really important is to have a broader understanding around how critical access hospitals are reimbursed and what is the overall structure for fixed versus variable cost. Now, when we talk about critical access hospitals, just for us to open our doors, a significant portion of our costs are fixed. And they're not going to change whether or not we serve 5 patients or 500 patients. The cost is inherently there as an organization. When we start to break down the differential between fixed and variable cost, we'll come to the realization that 90% of the cost for us as a critical access hospital is fixed, and only 10% of the cost can actually be changed through the providing of services or expansion or different things. Now, when we talk about our fixed cost, that's our core unit staffing, it's our medical direction, equipment, facilities, electricity, replacing equipment, all of that stuff is really our fixed cost. And I'll give you an example. If we're operating on a med-surg floor and we have 1 patient versus 5 patients, if we have 1 patient, we can't get rid of the number of nurses we have. It's not like we can go without nurses because we have 1 patient. However, if we only have 1 patient, we can also increase to 2, 3, 4, or 5 patients as we start to look at increasing those services. And we're not necessarily going to have to bring on additional staff to increase volume at the facility. Variable costs, which are really those things that change with each increase or decline in units of service, include our incremental medical supplies, specific pharmaceuticals, food and patient meals, all of those different things. Now, as we start looking at realization that we have a certain amount of fixed cost, we can start to strategically plan going forward and start to make initiatives as to where we can increase volume without having to increase cost. For instance, when we look at a program such as our laboratory department, most hospitals that operate a laboratory can increase their volumes by a material amount without having to bring in additional MTs or other staff. However, they may have to bring in additional reagents or additional things to actually process the lab test. So in that instance, a significant portion of the cost is fixed, and we could actually increase volumes without an increase on the significant cost for the organization. The variable costs are really those components that will go up as we start to increase our volume. Now, when we start to talk about programs also, it's very important to start to relate things to a contribution margin approach. When we look at the profitability of programs and from a contribution margin approach, we want to look at what programs can sustain themselves based on a direct contribution and what programs are requiring dollars from either other programs or mission dollars to sustain those programs. Now, when I say it to this degree, by no means am I saying we need to terminate services or cut services. What we really need to do is take a step back and evaluate the services that we're providing so that we can plan effectively going forward from a strategy approach to ensure that we can maintain financial solvency. None of us on the webinar today want to jeopardize the overall services that we're providing for an individual program or an individual service. But what we have to do is get away from the mindset of we can be everything for everybody in our service market. There's patients that need every single type of service that can probably be provided in the healthcare landscape within your facility, but we as organizations cannot afford or sustain to provide every one of those services for every one of those patients. So what we really have to start looking at is those services that truly will meet our patient need and demand, but doing so in a financially advantageous and sustainable way. The next opportunity really for our critical access hospitals is to really start to define a niche service or a special type of services that we can provide going forward. Now, when we look at our services as a critical access hospital, we can all provide the regular bread and butter type services. We all provide our acute care services to some degree. We all provide emergency department, lab, basic x-ray services, and so forth. Once we start to look at our scope of practice, we have to take a step back and start evaluating the services that we can provide to determine whether or not the providing of those services would allow us to expand access to care or expand our financial position as an organization. Now, up on the screen, I end up referencing a wound care program, and we'll talk specifically around the swing bed program. Now, when we talk about a scope of practice for our swing bed program, most critical access hospitals can provide your long-term IV antibiotics, they can provide your rehab services, and all of those core services within the swing bed program. What we as an organization need to do is take a step back and evaluate all of the services that could be provided in a swing bed program, for instance, and then start to evaluate, can we provide those services? Now, this will accomplish a couple different things for us. By identifying the different services that we can provide, we can identify, are there ways that we can start to target service growth with other facilities? Another opportunity, by identifying the services relative to the program, it'll also allow us to take a step back to identify maybe equipment that we need or the ability to increase staff competencies. Oftentimes, organizations will not go through and fully evaluate the scope of practice, and they'll have significant gaps in the ability to deliver care. Or what could also happen on the negative, if we don't fully evaluate our scope of practice, whether it's the emergency department, acute services, swing bed services, we may end up being in an environment where we take on patients that should not be receiving care within our facility. For instance, most critical access hospitals can't do neurology or significant cardiac services. If we haven't gone through the process of clearly defining and delineating our scope of practice, we may be in an instance where a patient is remaining at our facility because people are questioning whether we should be providing that service, as opposed to transferring that patient to a larger facility where they can more adequately receive the care they want. So again, go through, evaluate the services within each one of those programs, evaluate the scope of practice. One other thing to emphasize relative to the scope of practice that all of you are aware of, particularly operating within rural markets, is you bring in providers that have unique skill sets. You'll bring in nursing staff that have unique skill sets. You may bring in rehab staff with unique skill sets. Unless we evaluate the scope of practice and really work with our staff to identify those services, we may be losing out on opportunities because we have not asked our staff what they're trained in and what they're competent and capable to do. One last thing to emphasize with this also is, by identifying the scope of practice, you can leverage this as a way to start working with your CFO and CNO to start acquiring equipment or spending things more effectively within the organization. And I'll give you an example really quickly. The last hospital I was at, I worked very closely with the CNO. And what we did is we had gone through and identified the scope of practice, and she identified a couple pieces of equipment that they could use that would allow us to drastically increase our swing bed reliance. And it was a wound vac and then also some additional IV pumps. This allowed her and I to work together to quantify the net financial impact on the organization by acquiring that equipment. And it was able for me as a CFO to easily say, okay, by acquiring this equipment, it's going to flow through the Medicare cost report. We're going to get portions of it cost-based. It's going to allow us to increase our volumes. It was easy for me as a CFO to justify the expense and work with her to get that equipment, versus oftentimes what happens in many rural hospitals, a clinical staff person will go and say, oh, can I get this equipment? And the CFO will just say no. Again, because they're not working together to figure out how they can bridge that gap and how they can acquire the equipment for the patient needs. The next main focal point that we're going to talk about is really the provider complement. Now, in today's environment, the provider complement is really starting to change drastically relative to the providers you can get within your community, and also the ways that you can get those providers within your community. Now, one of the core things that we have to do within a rural health landscape is truly create a catalog of all of the providers and the types of services that those providers are providing within your primary service area and your secondary service area. Now, oftentimes organizations will create a catalog, and that catalog will only include the providers that they directly contract with or the providers that they directly employ. The catalog should include every provider in your service area, regardless of whether or not you have a relationship with that provider. And the reason for that is because as we start to look at expanding services or sustaining services, we have to take into account the total access to care and the providers that are providing those specific services. Now, just because we're able to bring on a provider, it doesn't matter whether it's another primary care physician or orthopedic surgeon, just because we're able to bring on another provider does not mean that we have to or we should bring on that provider. We have to evaluate it and make a comprehensive decision as to whether or not we could sustain that provider going forward. There's been many rural hospitals that I've gone into where I've had a conversation with the CEO, and the CEO will say, hey, we have an orthopedic surgeon that wants to come to our community, so we're going to hire this provider. And I'll say back to him, well, have you done any analysis? Have you quantified? Is there even a patient demand? Are there other providers in the community? And the comments will often be, well, no, but they want to come to our community, so we should hire them. We have to get away from that mindset, particularly in the rural landscape. And we have to start looking at reducing the duplication of services in a community to ensure solvency going forward. Now, this is not to say that if there's another provider type in your community that we don't want to bring that provider on. What it's saying is that if we want to bring on a specific provider, we have to be realistic as to an upward trend in profitability and growth and service utilization. And we can't just assume that because we bring a provider that we're all of a sudden going to be sustainable in that program. What we also have to start looking at is the alignment and designation of all of our practices. Many of you are probably aware that the Rural Health Clinic program fundamentally changed from a reimbursement approach specifically for our critical access hospitals tied to the Consolidated Appropriations Act of 2021. Now, through that bill, all rural health clinics now are subject to some form of an upper payment limit. Just depends on what upper payment limit you're subject to. Now, if you're a grandfathered rural health clinic, meaning that you owned, operated, and established your clinic prior to December 31st of 2020, or you had filed an 855A prior to December 31st of 2020, you are considered a grandfathered rural health clinic. And your rate is now established based on your 2020 cost report and then trended forward based on the Medicare Economic Index. If you're looking to establish a new rural health clinic as a critical access hospital, being any clinic after that 12/30/2020, those will be subject to the same upper payment limit as every other rural health clinic that's independent or owned and operated by a hospital with greater than 50 beds. So gone are the days of full cost-based reimbursement. You will always receive the lesser of the upper payment limit or your cost-based rate. So this is something we have to take into account as we're looking at bringing in providers or looking at integrating specialists into our facilities. Again, because we're no longer getting cost-based reimbursement as a rural health clinic, if we were to bring in a provider or if we were to incur significant costs through a facility replacement or some type of initiative, that may not come back to us in the way of Medicare reimbursements. We have to take these things into account as we start planning for things going forward. What I would also say too for our providers is we really in rural communities have to start benchmarking our providers to performance standards. Oftentimes we will see a provider in a rural market that will be in the 80th percentile for payment, but only in the 30th percentile in productivity. We have to start merging these two together and start comparing our providers and paying them effectively relative to their panel sizes and the services that they're providing. We have to conduct our Stark analysis. We have to do our fair market assessments. We have to do all of these things as critical access hospitals, again, to ensure we don't get in trouble or we get into an unsustainable model going forward. The last thing to really focus on relative to our provider complement is really looking at how we compensate providers going forward. Now, if we go back a decade, many organizations would just pay a provider a fixed contract. We'd pay them $225,000 a year to provide certain services for our organization. As we continue to move more towards population-based initiatives and outcomes, we have to start to change how we're compensating our providers. We have to incorporate work RVUs. We have to incorporate panel sizes, satisfaction scores, quality scores. All of those things should play a role in how we are compensating our providers. Because what's happening is if we continue to pay a provider just based on a fixed contract, what is incentivizing them to go out and see more patients? On the inverse of that, if we're paying a provider just based solely on work RVUs, what is incentivizing that provider to provide high quality care or to improve patient outcomes? Again, we have to realize that the payment methodology is starting to change, and we have to start to incorporate that into our provider contracts. Now, what we can't do is just change our provider contracts tomorrow and say, here's the new methodology, good luck, because we may have a mass exodus from our providers. We have to start increasing the conversations and working with our providers to get them to realize that the landscape is changing, and we also have to start changing the landscape for them. Now, this is oftentimes easier for providers that are just coming out of medical school or just coming to your organization than it is to work with providers that have been at your organization for 20 years. But nonetheless, we have to start to move the needle to align incentives and payment to how we are being reimbursed and evaluated as organizations. The next area is really around acute care services. Now, acute care services, we've often seen decline in recent years, particularly for our critical access hospitals. We have to start taking a proactive approach to leverage efficiencies and the ability to provide the relevant services within our critical access hospital that should be provided at that hospital. Now, many of you, when we look at cost reports and look at different things, we've seen an increase in the number of observation days relative to the acute care patient days. And this is because most insurance companies are starting to deny claims for acute care inpatient admissions and trying to push them towards observation levels of care. We have to start to leverage things such as Milliman or Interqual or different things as a way to reduce variation among the providers, but also as a way to start to substantiate patient admissions. If we look at UHC, which is one of the largest healthcare entities from a health insurance perspective, they have started to integrate Interqual into whether or not they could determine medical necessity from denying a claim on their end. So if they're using these care guidelines as a way to start to evaluate patients, we have to start to leverage those means as a way to substantiate patients going forward. We can no longer have the variation among providers or not adequately document to substantiate patients receiving services within our facilities. We also have to start to look at different ways and methodologies that we can provide inpatient care. If we're a critical access hospital, unless we have a 20-person average daily census on an annual basis, it's hard for us to sustain a true hospitalist model. We have to start looking at alternative means as a way to provide hospitalist services, whether we're leveraging a telehospitalist program or whether we're leveraging different providers. Again, we have to look at different opportunities as a way to sustain those programs. Another opportunity for you that are operating rural health clinics that have significant swing bed volumes. Have we looked at integrating our providers that are providing the swing bed inpatient care into the rural health clinic and billing those out as an RHC covered service? This is a way that we can also help supplement the cost for our hospitalist unit. Another opportunity also is, have we looked at having our rural health clinics reach out to maybe area nursing homes to also look at providing the inpatient coverage for those nursing homes? Again, oftentimes we see with critical access hospitals, volume is the solver for the financial position of your organization. We have to start looking at proactive ways to go after volume for those services that we're providing. As I talked earlier about the scope of care, this is something we also want to do specifically for our inpatient unit. We want to evaluate the services that we're providing across all of the different providers and the full continuum within that department. We want to ask our nurses, we want to talk to our pharmacists, we want to evaluate medical equipment, rehab. Again, we want to look across all of those different departments to ensure that we're taking everything into account when we're determining and deciding what type of services should we provide within our facility. Again, one of the worst things that we can do as an organization is to accept a patient that we're not adequately prepared to care for. If we can go through and define that scope of care and scope of practice and get those patients more readily or quickly transferred to appropriate facilities, it only will improve the outcomes for that patient themselves. The next area is really around multidisciplinary approach. Now, oftentimes we continue to see a segmenting within our med-surg floor. Oftentimes the providers don't talk to nurses, nurses may not talk to CNAs, and so forth. We really have to start implementing a multidisciplinary approach that includes bedside handoff and hourly rounding to really focus on patient outcomes. Patients in today's environment are much more pertaining to and involved with quality of life and patient care than we could when we realized we were doing these services 20 years ago. Patients really want to be more actively involved in their healthcare services and not really somebody there just receiving the services. We have to start to integrate those things going forward. We also want to ensure that the pharmacist plays an active role in the actual delivery of care, particularly on the inpatient side. Oftentimes, we will see patients that are discharged from an inpatient facility back to home, and they never met with a pharmacist to discuss medications or follow-up medications that they'll need going future dates. Again, we want the pharmacist to play an active role. All of these things will only improve outcomes and improve patient satisfaction by taking a more proactive role in engaging our patients around the delivery of care. Now, the last area is really around staffing for our med-surg floor. Now, organizations that we see, particularly in rural environments, they tend to titrate their staffing ratios based on the patient panel size they have. And what I mean by that is, as the average daily census continues to drop, maybe they used to operate a ratio at a 6-to-1 for med-surg, and now their patient panels have dropped down to where they're at a 4-to-1. It's very difficult to get back to that 6-to-1 ratio. We have to benchmark our staffing, and we have to benchmark particularly departments such as med-surg with significant cost back to industry standards. Now, when we look at an ICU type program, those are closer to 3-to-1. When we look at med-surg in an acute care setting, those are 5 to 6-to-1. When we look at swing bed services for nurse to patient ratios, those are closer to 8-to-1. Again, we want to vary these things and take these into account as we're staffing our different programs. In addition to that, we also want to operate in an environment where we get people performing at the top of their license. What we don't want to do is we don't want to pay a physician or an APP to do something if that could be done by a RN. We don't want to pay an RN to do something if a CNA can do that service. Again, we want to look at these things across the organization and have people provide the services that they can do going forward in an appropriate care setting. We have to get away from certain providers or individuals doing services just because they like doing those services. We have to start realizing the efficiencies and leveraging those programs going forward. The next area is really around swing beds. Now, swing beds is an area in a program that can really help financially sustain, particularly a critical access hospital. Because of the cost-based nature tied to our critical access hospitals and how we are reimbursed through our swing bed program, it plays a vital service for those patients and for that hospital as a whole. One of the key things that we have to do as a swing bed program is we have to take a proactive approach in actually going after to get patients. The swing bed program is different than probably any other service we're providing at our critical access hospital. If a patient needs emergency services, they come to your emergency room. If they need diagnostic imaging, they come to get an x-ray. If they need lab work, they come to get the lab work. With our swing bed program, these patients are already in a healthcare environment. They're either in our acute care beds or they're already placed at a large tertiary facility. What we have to do is we have to start to reach out and engage those other facilities around the ability to provide swing bed services. Now, if you were to reach out to one of those larger organizations and have a conversation around swing bed services, when they're a case manager at that larger facility, they may have to place 20 or 30 patients a day. So what they're looking at is where can they place the most number of patients quickly so that they can free up beds to take other patients in an acute care DRG reimbursement setting. So when they're looking at organizations to reach out to, who are they going to call? A 100-bed SNF that can take 20 patients at a time, or a 20-bed critical access hospital that may only have 5 or 6 beds available at a time. So what happens is we often end up putting ourselves in a position where we get the patients that have already been passed over by all those other facilities. the patients with multiple comorbidities, the patients with no Medicare days left. Those are the patients that often get referred to the critical access hospitals because they could not receive care elsewhere. What we have to start doing is taking that proactive approach and going after patients at other facilities. We should be having a person dedicated and calling those larger facilities every single day to touch base on what patients you could take at your facility and when you can start getting those patients into your facility. We have to look at it to that degree. Another thing we also have to do is we have to get our providers into playing a proactive role into prior authorizations and the denials relative to medical necessity. Oftentimes, if a patient is denied due to medical necessity, it's the provider that's going to have to come up with additional information or substantiation to justify why that patient was in that swing bed. So we have to start getting them involved. Oftentimes, we go into organizations where once the claim becomes a part of revenue cycle, the provider doesn't really play much of a role after that if any issues ever pop up. Get the providers more involved and active in the delivery of care and the actual substantiation of the delivery of care so that we can start processing those claims and getting them adjudicated and paid for. When we look at those services across Medicare, Medicare will predominantly pay us for the services that are provided in a swing bed setting, so long as we submit the claims appropriately, the patient has Medicare days of eligibility, and so forth. Now, when we talk about swing bed program again, one of the biggest opportunities that we see for critical access hospitals is really around the admissions process. Now, when we compare a critical access hospital to a SNF or some other post-acute care provider, those other entities can generally make a yes or no decision relative to a swing bed patient in anywhere from 1 to 2 hours. When we look at our critical access hospitals, it generally takes them anywhere from 4 hours up to multiple days to make a yes or no decision relative to a swing bed patient. And if it's taking your organization a couple days to make a decision, the likeliness is that patient has already been placed at another facility. So what we have to do is come up with a streamlined process that evaluates our swing bed program and can get through that quickly to start to make that yes or no decision. We also want to involve those that are critical to the decision-making process. If we're bringing in a swing bed patient that needs pharmaceuticals, we don't want to ignore or not talk to the pharmacist to see that we actually have and can get that medication. If we're bringing in a Medicare patient, we want to ensure that they actually have Medicare days of eligibility. So we want to talk to the business office. We want to ensure that we have the medical supplies. We want to talk to rehab to make sure that they meet the skill requirement for rehab services. And then we also want to talk to the pharmacist to make sure that they actually meet medical necessity for the swing bed services in our program. We want to be able to go through this entire process within an hour to two. What we also want to do too is, because generally the physician is the highest costing individual, we want to evaluate patients and to try to exclude them prior to going through the entire process. For instance, if we can deny a patient because they don't have any eligibility days or we can't get a medication, why would we take that to the provider and have them evaluate the client or the client record if we can't take them into our facility already? Same thing, if we don't have medical equipment to care for a patient, why would we have our physician review that record if we can't take that patient already? So again, we want to evaluate to all of these different degrees. The next area around swing bed, and this is another missed opportunity that we see oftentimes with critical access hospitals, is specifically leveraging the swing bed NF rate as a way to drive business to your facility. Now, the way the critical access hospital's cost report works is the only days that go in to determine your daily routine rate is your acute patient days, all of them, doesn't matter if it's Medicare or commercial or so forth, your swing bed SNF days, and your observation days. Your swing bed NF days, which are all patient days besides Medicare and Medicare Advantage, get carved out at the daily NF rate. Now, what I mean by that is we come up with a fully allocated cost for our med-surg program. And then what we do is we take all of the Medicaid, the commercial, the workers' comp, self-pay, all of those days, and we multiply that by the daily NF rate and then subtract that from the fully allocated cost before we determine that daily routine rate, which is then our cost-based daily routine rate that is used for our Medicare and swing bed days and acute care days. The way we can leverage the NF rate is by figuring out what that NF rate is. We can then leverage that rate to go and negotiate with larger facilities and also with commercial payers as a way that we can start getting patients into our facility. So if our daily cost-based rate is $1,000 as our routine rate, and we're getting a commercial payment rate of $500, if our carve-out rate is only $250, whereas again, they're subtracting $250 of cost from our rate each day, we can make $250 profit by taking a patient in that post-acute care setting. Oftentimes, organizations think that they need to get that daily Medicare cost-based rate in a swing bed program to be able to break even or turn profit, and that's not the case. For all non-Medicare business in a swing bed program, we just need to get in excess of that daily rate. Now, when we talk about growing our swing bed program, a minor increase in our average daily census can have a substantive position or improvement on our net financial position. Now, the example up here that we're looking at, by increasing the average daily census only by 2, so not 6, not 10, I'm not telling you to double, by increasing your census by only 2 would improve the net financial position for this organization by $250,000 a year. So again, minor improvements can have a material impact on your financial performance going forward. It's something we have to start looking at and taking into account. The next area is really around emergency services. Now, when we talk about emergency services, the biggest opportunity for critical access hospitals is to put ourselves in a position where there is not an over-reliance on our emergency department for non-emergent services. Oftentimes, we may hear of people say, oh, the emergency room's a Band-Aid station, or it's not being utilized appropriately. The emergency department is one of the most costly programs that you can provide within your hospital. And what we don't want to do is continue to operate in an environment where patients are coming to the emergency room for non-emergent services. Now, there's several ways that we can evaluate this across the program. We can look at the services that are actually being provided. We can look at the distribution between 99281s, 2s, and 3s relative to 4s and 5s. Are they more low-level services or are they more high-level services? We can also look at when the patients present, are they actually, based on medical necessity, meeting the requirements to actually get emergency services to that degree? Now, there's other ways that we can look at how we can benefit the program. We can look at an ED redirect program. We can look at extended hours clinics. All of these things are ways that we can improve the financial position of the organization by getting patients more appropriately placed in a level of care. Now, because we have to provide 24/7 provider coverage in the emergency room, that's usually staffed all with nurses that are on the higher end of the pay scale. Again, we don't want to continue to have patients going there that require us to have more nurses, more provider professional time versus standby time to that degree. We want to ensure patients are getting services appropriately. The next area is really around revenue cycle. Now, when we talk about revenue cycle, and we're going to have several presentations on revenue cycle in the coming months, what I would say about revenue cycle as a best practice is we have to start to realize that if we spend more time on the front end processes in revenue cycle, it'll save us exponentially on the back end. Oftentimes, organizations think that revenue cycle starts at the point either the patient presents or when the claim actually starts to get coded. Revenue cycle starts long before the patient ever shows up at your facility. Revenue cycle is payer contracting, payer credentialing. Revenue cycle is claims contracting. It's doing all the initiations. It's the credentialing. It's point of service collections. It's all of those things on the front end process. Your charge description master, pricing, all of those different things are a part of revenue cycle. When we start focusing on the process of the front end, we can start to improve the outcomes on the back end. For instance, are we always checking insurance cards when patients come in? Are we checking copays or taking copays? Are we doing all of those things on the front end process? It'll save us exponentially on the back end. Organizations that continue to expend efforts on the front end see material increases on improvement in the back end relative to net days AR, clean claims ratios, first pass ratios, point of service collections, all of those key metrics that we should be looking at and tracking within our revenue cycle department. We also want to break down the silos between revenue cycle and our providers. Our coders should be regularly meeting with our providers, discussing changing and coding requirements and terminology and all of those different things to continue to educate our providers on different ways that we can improve performance. Everybody's favorite subject, cost report. Now, I talked earlier about the cost report and really how it is a document that we really have to start leveraging within our organizations. Now, when we talk about the cost report as a whole, we really have to look at how we can merge the art and science of cost report preparation. Many organizations will look at the cost report as purely an administrative function, something that has to be completed on an annual basis, and that couldn't be further from the truth. We have to start looking at the operational components that go into our cost report and how we can leverage how we are operating to drive where and how we're putting information into the cost report. These things will have a material impact on reimbursements and the accuracy of the information within there. Now, in addition to that, we can also leverage the cost report as a way to evaluate our organization as a whole. For instance, we can leverage the worksheet C as a way to look at our charge structure and are we passing on too much cost to the beneficiaries? We can look at our AA adjustments around standby time and are we getting enough reimbursements for the standby cost for our providers? All of these additional things are different ways that we can leverage the cost report as a way to drive performance going forward. Another opportunity is to look at the worksheet B-1. How are we stepping down the stats and how are we allocating costs to all of the different departments that are our revenue generating departments within our hospital? Oftentimes, again, we will look at the stats and see that the stats have not changed in years and organizations are continuing to step down costs where that cost should not be going to. And frankly, it would be more advantageous for the organization if they step down that cost to an appropriate location. Now, I know I've gone through a lot of different things very quickly, and what I really wanted to do was lay the framework for all of the coming presentations. This document, even though I didn't go through everything in detail, can really be leveraged as a way that you can look at different parts of your organization to see how you're performing in different ways as to how you can improve performance going forward. So I'm going to pause now to see if there's any questions that I can answer relative to any of the topics covered or anything else that maybe is popping into your mind right now that at least is
Thank you.
relevant to the topics today.
And thanks so much, Jonathan. I've actually gotten some private messages in the chat thanking us for bringing you because it's been such valuable information to start us out with here. So we are entering the Q&A portion of our webinar now. So please enter your questions into the Q&A box on the right-hand side of your screen or raise your hand and we'll unmute you so that you can ask your question live. I do have a couple of questions off the bat here, Jonathan. Can you provide any examples that help leaders drive their organization's culture toward an integrated quality finance and performance improvement organization?
Yeah, it's really, there's several examples across the country. And when we look at it across the culture, it's really getting everybody at the table up front. And it's pulling in not only the executive team, a lot of organizations try to manage from the top down. And in rural environments, that really just doesn't work anymore. We have to realize that our frontline staff have a direct impact on the performance of our organization, and we have to start including them in some of those performance improvement type initiatives. So I'd say that's one of the first things that we can do from a cultural approach is to break down the siloing between finance and quality. Most of your organization probably has everybody roll up to either the CFO or the COO. Starting to get those two working together is really one of those things that will really start to transcend or change the culture of your organization. Then as we start to focus on those performance improvement initiatives, if we're focusing on something in the emergency department, bring in an ED nurse. If we're doing something in med surg, bring in a med surg provider. Don't think that we can do it without involving those staff, because oftentimes when we're starting to focus on those functions, many of the times those people will have the answers to a lot of questions that we're asking, and we can get those things done a lot quicker if we start including them in the conversations.
Great, thank you. And that kind of leads into the second question I have here. You kind of covered it a tiny bit in your response to that last question. But we've seen quite a bit of staff turnover at CAHs over the course of the last few years in Oregon, which is not dissimilar from the rest of the nation. So what advice do you have for CAHs that are struggling with this turnover, especially among leadership teams, in terms of how to continue working toward best practices you've outlined here to ensure continued progress going forward?
I would say that, and that's a great, and it's something that's experienced by hospitals across the country. What I would say is what we don't want to do is we don't want to promote people beyond their comfort level to start. That's not good for anybody because people will start to burn out and people will be put in bad positions. What I would say is there's different ways that we can leverage certain experiences, whether it's interim management, whether it's teletype, say we're missing a coder or a biller. A lot of these services can be provided distant site now. They don't all have to be on site. I know of several hospitals that are actually bringing in temporary, like a CFO, where they have a CFO that's providing services on a contract type basis, where they're providing that CFO type work, but then the organization has somebody doing all the day-to-day accounting. So it really depends upon the position that you're looking for. But I would realize that we have to start thinking outside of the box. Not all of us are going to be able to get every single worker into our community in the next 30 days, 60 days, or even 6 months. But there's ways that we can access that experience to ensure that we're getting the information we need and the actual experience that we need relative to those positions.
Great, thank you. I don't see any other questions in the chat, but we'll just pause here for a couple of seconds and see if other questions come in. While we do that, Jonathan, can you move on to the next slide? I wanted to put some announcements in here to let you all know what's coming up from the Oregon Office of Rural Health. So first of all, we have our Forum on Aging in Rural Oregon that is coming up May 15th through the 17th, and that is in Seaside, Oregon. And then we have our CAH Quality Workshop, which is actually co-located with the Aging Forum in Seaside, May 16th and 17th. Both of those events, registration has opened for the Forum on Aging, and the Quality Workshop registration will be opening shortly, and you'll receive information from Stacy Rothwell about that. Um, we also recently released our unmet need uh, healthcare report on our website. There's a link on the slide. You'll all receive these slides as kind of a follow-up to this webinar, along with the recording. So don't worry about those clickable links that you can't click on right now. You'll be able to click on them when you get the slides. And then a reminder that our next webinar with Jonathan, a systems approach maintaining a high functioning revenue cycle department, will be held on March 9th at noon. All of these webinars are being held on Thursdays at noon. We have 2 in March. So please do peruse that website that I put in the chat for what's coming up, and make sure that you register for them. I don't see any other questions in the chat. So I think with that, we will wrap up for the day. A survey will pop up after you exit this webinar. Please make sure that you take a moment to complete it, as it really helps us continue to build upon these programs and to bring these programs again in the future. And I really want to thank you again, Jonathan. This was a great start, valuable information. We really appreciate your expertise here.
Yeah, I appreciate the opportunity to present to everybody.